Welcome to our series Inside the OR. Today we are going to review the surgical tenets of the middle fossa peeling on a case of a lateral third sphenoid wing meningioma. Perform a Minipterional craniotomy with inferior margin of the craniotomy flat with the middle fossa. The sphenoid wing is then drilled flat with progression of cutting and diamond drills. I recommend the use of diamond drills on the middle fossa meningioma as heat from the drilling allows to achieve hemostasis of this hyperostotic bone. In sphenoid wing meningiomas, I personally prefer to perform a small lateral orbitotomy, like in this case. This is important not only to treat the retroorbital pain in patients with tumor of this kind, but it's also helpful to find the meningo-orbital band at the level of the superior orbital fissure. The meningo-orbital band is coagulated, and with a pamphlet number 1, we expose the epidural space minimally, both in the frontal and temporal dura, and this allows to minimally delineate the meningo-orbital band. Notice how the microscope is tilted down and is positioned pointing perpendicularly to the middle fossa. Here we start the middle fossa peeling by sectioning the meningo-orbital band. Then, while I use dynamic retraction with the tummy of the suction, I use the scissor to sever the external meningeal layer. This maneuver opens the interdural space, and once at this interdural space with the concave surface of pamphlet number 1, I retract the external meningeal layer to expose the lateral wall of the cavernous sinus and megalscape. By doing this, we have access to the anteromedial surface of the meningioma, and it can be now devascularized. We achieve hemostasis of this space with direct injection of flow seal and gentle compression with a patty. Now, dura overlying the tumor is coagulated with bipolar for devascularization, and prior to open the dura, we attain some tumor debulking and send a specimen for frozen analysis. Then we incise the dura of the convexity over the tumor margins to find the plane between the tumor and the arachnoid space. Using high-by-3 cottonoids, we create some contraction to expand the dissection plane while preserving the arachnoid for a smoother dissection. Once we work through the posterior temporal margin of the tumor, we expand our anterior cut over the tip of the temporal dura, and we connect with the epidural space that we delineate during the peeling of the middle fossa. Because of the middle fossa peeling, we have been able to devascularize also the middle margin of the tumor, as we said previously. See how this priorly skull-based meningioma, we transform it into a convexity meningioma in which we have access to all its margin to achieve the vascularization of the tumor. Then we just need to work our way through the frontal dura and connect with the temporal cut to fully untether the tumor from its dura margin. Now we just need to complete the critical step to dissect the tumor off the deep arachnoid plane. Here in sphenoid wing meningiomas, it's extremely important to preserve the deep venous system. As you can see here, we use a nerve hook for the assistant to traction the tumor slightly, but note that the sharp dissection is needed to preserve the Sylvian vein. See how I emulate grasping the arachnoid with the scissors and traction towards the vein, and how I use the scissor close as a sharp dissector to aid with the peeling. See how prior devascularization allows for a clean feel? Avoid, in this case, cutting too close to the vein. A sharp dissection of the arachnoid just 1/4 of an inch away from the vein is enough to peel the tumor capsule off. At some point, the tumor is too large to see under this vein, so I prefer to do some debulking. And now, to avoid working with the assistant in such a narrow corridor, I can traction the tumor by sucking the tumor with my suction tip. And finally, we complete the sharp dissection of the Sylvian vein. Thanks to the peeling of the middle fossa, we were able to achieve a gross total resection, Simpson 1. Reconstruction is carried down with a inlay duragen and pedicle superfascial flap over the defect. So in summary, when the venous system is preserved in the sphenoid wing meningiomas, the recovery is fast, such as in the case of this patient who was discharged within less than 24 hours and currently remains seizure and tumor-free at 2 years follow-up. I hope you like this technical review, and comment, give a thumbs up, and subscribe for more. Thank you.